So in this second section regarding peptic ulcer disease, we'll be studying about the management. With the development of histamine receptor antagonist and proton pump inhibitors, there's been a very wide range of changes within the management of peptic ulcer disease. So we'll be studying about different clinical features and alarm features. What are the alarm features that a patient might present with, and what are the next steps that we should do with those patients? We'll be studying about different types of diagnosis for the peptic ulcer disease and the medical therapy that we can provide to these patients with peptic ulcer disease. So if we talk about the clinical features, how does a patient present with? The most predominant feature that a patient might present with is epigastric pain. So this epigastric pain, it is usually associated with hunger, or the pain usually presents at night and is relieved by food or taking antacids. The patient might also present with symptoms such as bloating or bloatedness and fullness. And other than that, the patient might present with heartburn within the chest. The patient with more complicated type of features patient might present with ulcer bleeding within the gastrum and the perforation. The bleeding and perforation is more of a serious complication regarding peptic ulcer disease. So if we talk about alarm features, the different types of alarm features that if a patient presents within the OPD, the clinician or the physician should be very alarmed. These includes if the patient presents with a very new onset of dyspepsia and the patient is above 55 years old. If the patient has a family history of upper gastrointestinal bleeding or cancer, the patient might present with gastrointestinal bleeding and an unexplained anemia, which is iron deficiency anemia. The patient might also present with yellowness of the eyes or the skin, known as jaundice. Patient might also present with the left supraclavicular lymphadenopathy, which is called as Virchow's node, which is very specific to gastric carcinoma. There might be a palpable abdominal mass when palpated, which is also suggestive of any growth within the stomach. Patient might present with persistent vomiting and nausea. There might be progressive dysphagia. The patient might complain with pain with swallowing or difficulty with swallowing. And lastly, the patient might present with unintended weight loss throughout the years. If a clinician asks the patient if he has witnessed any weight loss within the past few years, and the patient might say yes. So these alarm features are helpful in accurately diagnosing the patient with peptic ulcer disease, and also diagnosing, these are diagnostic features for any type of neoplasia that might occur within the stomach, which is an ultimate complication of peptic ulcer disease. So these type of patients, they're promptly sent for an endoscopy to rule out any growth or any neoplasia within the stomach or the duodenum. So if we talk about the diagnosis, the main method and the method of choice for the diagnosis of peptic ulcer disease is esophagogastroduodenoscopy. So this is the treatment. This is the diagnosis of choice, and it is usually very sensitive and very specific as compared to any radiographic studies such as the barium swallow or the X-ray studies. Although endoscopy is very expensive and it has potential for complications, but it still is the investigation of choice. So gastric ulcers or duodenal ulcers might occur, and with the help of gastric mucosal biopsies and rapid urease test, very easy to diagnose a Helicobacter pylori infection, which is one of the major causes of these peptic ulcer diseases. So in this diagram, we can see that there's an endoscope which is called as esophagogastroduodenoscopy because it passes through the esophagus and then it passes through the stomach, which is gastro, and then it can also pass into the small intestine, which is the part of the duodenum. So now if we talk about test and treat, this is very important regarding peptic ulcer disease. So if there's a patient who presents with dyspepsia and you've ruled out that this patient does not have gastroesophageal reflux disease, or the patient does not take any NSAIDs or aspirin, so this type of dyspepsia should be ruled out. So how do we rule it out? First of all, we are going to see the alarm features. If the patient is above 55 years old or has those alarm features such as persistent vomiting or has a history of family history of gastric cancer, or there's an unintended weight loss, like I've mentioned all those alarm features before. So if the patient presents with these alarm features, so the patient is directly sent for an endoscopy without a doubt to rule out any type of gastric cancer. Other than that, if the age is less than 55 years old and the patient does not present with any of these alarm features, so the next step would be that we test the patient for Helicobacter pylori infection, as Helicobacter pylori infection is one of the major causes of peptic ulcer disease. So if the test is being done for the patient and the patient comes with a negative uh, uh, result, so the patient is given proton pump inhibitor trial for around 4 to 6 weeks. So if the patient comes after 4 to 6 weeks and the patient still has the symptoms of dyspepsia, so it naturally it shows that the patient has failed with the treatment of proton pump inhibitor. So this patient is usually reassured and then the diagnosis is reassessed. And still, if the patient presents with dyspepsia, then we're going to be considering endoscopy. So now, if that same patient who has been tested for Helicobacter pylori infection, and if he has been presented with a positive result and the patient has Helicobacter pylori infection, so we are going to be treating him with the management of Helicobacter pylori infection. And then if this treatment also fails and the dyspepsia still persists and the patient still presents with dyspepsia, so we are going to be giving him proton pump inhibitor trials for around 4 to 6 weeks, the same way as we've given before. And naturally, usually patients, they present with a successful treatment after proton pump inhibitor. So now, if this patient also fails the treatment and the patient still persists with the symptoms of dyspepsia, so we are going to reassure and reassess the diagnosis, and ultimately then we would be considering endoscopy. So overall in this, we've seen that if a patient presents with alarm features and has and the patient is a little older, with an age more than 55 years, we're straight away going to send the patient for an endoscopy. And if the patient has no alarm features and is of a younger age, then firstly we're going to test him with Helicobacter pylori infection. If it's negative, we're going to be giving him proton pump inhibitors, and if it still fails, we're going to send him for endoscopy. And if the patient has a positive result for Helicobacter pylori infection, we'll treat that infection firstly, and then if still the dyspepsia persists, we will give him proton pump inhibitors for 4 weeks. And if even after the treatment of Helicobacter pylori infection and proton pump inhibitors, the patient still comes up with the symptoms of dyspepsia, we're ultimately going to send him also for an endoscopy. So if we talk about the medical therapy, what are the pills and what are the different type of medicines that we can provide the patient with? Firstly, there's a group of antacids that can be given to these patients. These antacids usually neutralizes the gastric acid. The exact precise mechanism is unclear, but there's a study going on that it neutralizes the gastric acid, and this finally causes a decrease in the ulcer production. This antacid is usually not given as a primary therapy, but it is given to relieve these dyspeptic type of symptoms. So the most common adverse effect regarding antacids is diarrhea, but some of the antacids the patient might also present with constipation. And these antacids are usually given very cautiously in patients with chronic kidney disease because the magnesium containing antacids can cause hypermagnesemia, and the calcium containing antacids can cause hypercalcemia, and the aluminum containing antacids can cause neurotoxicity. So now we come to the main treatment of peptic ulcer disease, which is the anti-secretory agents. So the first being the histamine 2 receptor antagonists. So these histamine receptor antagonists are very competitive inhibitors of histamine stimulated acid secretion. So what really happens is that the histamine that causes the gastric acid production, so these antagonists, they go to these histamine 2 receptors, and they have an antagonist type of effect. They completely block these receptors, and thus gastric acid secretion is decreased. So they suppress the acid secretion, and usually the peak blood levels after an oral dose is usually around 1 to 3 hours after the oral dose. So it is very safe and well tolerated by most of the patients with peptic ulcer disease. So the examples of histamine 2 receptor antagonists are such as cimetidine, ranitidine, and famotidine. If we talk about the adverse effects of cimetidine, it's usually any gynecomastia or impotence. And the side effect of ranitidine could be encephalopathy. So the second type of anti-secretory agents that is very popular these days is the proton pump inhibitors. So these proton pump inhibitors, they usually decrease the gastric acid secretion by inhibiting the hydrogen and the potassium ATPase. So this causes a decrease in the gastric acid secretion. The peak serum levels is usually not achieved until after 2 to 5 hours after the oral administration of the proton pump inhibitors, and these proton pump inhibitors are also very safe and well tolerated. The examples of proton pump inhibitors could be osomeprazole and rabeprazole, and they're usually side effects. They're not very prominent side effects, but they're usually associated with some diseases such as osteoporosis and gastric polyps and enteric infections, which are infections within the intestine, and they're also associated with pneumonia. So the third type of medical therapy that we can provide the patients with is the mucosal protective agents. There are different type of mucosal protective agents. First being the sucralfated sucrose, which is sucralfate. So sucralfate also is equally effective to histamine receptor antagonist, and it is also usually given to patients widely around the world for the treatment of peptic ulcer disease. The second being the colloid bismuth preparations. There are two types of these bismuth preparations. One being the bismuth subcitrate and the second being the bismuth subsalicylate. So this bismuth preparations are also very useful in the treatment of peptic ulcer disease, and they usually present with side effects such as simple diarrhea. And the third type of mucosal protective agents are the prostaglandin E1, being the misoprostol. So misoprostol is more of a treatment given for prophylaxis. It prevents the development of these ulcers within the stomach and the duodenum, and it usually causes diarrhea, and it is highly contraindicated in pregnant women. So now if we talk specifically about the Helicobacter pylori infection and how are we supposed to treat the ulcers regarding Helicobacter pylori infection. Um, Helicobacter pylori infection causes around 80 to 90% of the duodenal ulcers rather than the gastric ulcers. So if a patient presents with Helicobacter pylori ulcers, it's very important to test the patient for this infection first. And the therapy that is given, the Helicobacter pylori eradication therapy, is usually given for around 10 to 14 days, which is around 2 weeks of this treatment. And there's also a 1 week of antibacterial therapy without the acid suppression, which is also advised for these patients. As you can see in this picture, this is a picture of Helicobacter pylori infection, which is a rod type of an microorganism, and it causes inflammation and epithelial damage to the epithelial of the gastric mucosa, and ultimately it causes gastric ulcers and duodenal ulcers. So if we talk about the treatment of specifically NSAIDs type of ulcers, the foremost thing is that we're going to advise the patient to stop the use of aspirin and NSAIDs. So the treatment includes the use of histamine 2 receptor antagonist, which is very effective in healing the NSAIDs related gastric ulcers and duodenal ulcers. Second being the most famous proton pump inhibitors, which are also superior to standard dose of histamine 2 receptor antagonist. They're more used in the treatment of NSAIDs ulcers, and the ulcers are usually healed at around the 8th week. And finally, misoprostol, which is also used, which is used more as a prophylaxis treatment. It is also used, but it is not as effective as proton pump inhibitors. So among all these three, regarding histamine 2 receptor antagonist and misoprostol, proton pump inhibitors are widely used for the treatment of NSAIDs and aspirin-induced gastric duodenal ulcers. This is all from this section. We've studied about the clinical features, diagnosis, and treatment of peptic ulcer disease. To learn more about peptic ulcer disease, do watch the other section regarding this topic. Thank you for watching sqadia.com.